can hear me? I think it's a little loud, maybe. So I'd like to thank Dr. Hamdan and Dr. Salman for inviting me to this conference. This is my first time in the UAE, and it's been wonderful. The food last night was incredible. It was like Thanksgiving on steroids. So let me see how this works. How do I move the slide? That's forward. Okay. So I do have two disclosures. I own a medical device company that I started, which is irrelevant to this discussion, and I'm on the board of CARES Foundation, which is the largest foundation in the world treating and advising patients and families with congenital adrenal hyperplasia. So today we're going to talk about not surgical emergencies, but genitourinary issues that need to be considered by every pediatrician. You're going to see these in treating your patients, and we're going to start with the acute scrotum. A friend of mine sent me this. I have no idea where it was taken, but it's really bizarre and funny. So the three main causes of the acute scrotum include epididymal orchitis, the torsed appendix, testis, or epididymis, and testicular torsion. And in the past, this was a challenging diagnosis, and every kid went to the operating room when they presented with this very often. But today, we reserve surgery for patients with a strong clinical presentation for testicular torsion and those with equivocal clinical presentations that demonstrate decreased or non-diagnostic perfusion on radiologic imaging, which is usually ultrasound. So we're going to start by discussing testicular torsion or torsion of the spermatic cord. And this occurs in males who have, as their embryologic development occurs, there is an abnormal fixation of the tunica vaginalis to the spermatic cord and testis. And if you have that anatomy, then in the presence of a strong cremasteric reflex, usually occurring during nocturnal erections, a traumatic event or exertion, or a rapid growth spurt in adolescence, that can trigger the testicular torsion. And what you're seeing, this is the testicle with the epididymis. The tunica vaginalis has been removed, and you can see how the cord can twist. Normally, the spermatic cord, the tunica vaginalis invaginates the anterior aspect of the testis, and this is a normal formation. But in boys who are susceptible to having testicular torsion, the tunica vaginalis surrounds the entire testicle up to the spermatic cord. And if you can envision the tunica vaginalis acting as a bell, with the testicle as a clapper inside the bell where it can move freely, as opposed to having the posterior aspect attached and not able to rotate. This can rotate within the sac and cause torsion of the distal cord. If we look at the incidence of testicular torsion in males, it's about 1 in 4,000 in those under age 25, and they tend to peak in two age groups. Those within the first 6 to 8 weeks of life, and we'll talk about those separately. That's called neonatal torsion, and that is different than adolescent or adult torsion, which tends to occur in the adolescent age groups. The presentation is typically a sudden onset of severe pain. It's associated with nausea and vomiting in 30 to 80% of patients, and there's often a history of having intermittent testicular pain in the ipsilateral testicle. These patients, over half of them, if you get a history, will have had intermittent severe pain in the past, and that's intermittent or partial torsion leading up to the actual torsion event. The pain level can be highly variable depending on the degree of the torsion, whether it's 180 degrees or a complete torsion at 720 degrees. Typically on exam, you'll have extreme tenderness of that ipsilateral testicle. The testicle often has a horizontal lie, which is quite obvious in many kids if you detect it early. And because the cord twists, the testicle gets elevated, so it's a high riding testicle. Sometimes they can be all the way up in the inguinal canal. There's an absence of a cremasteric reflex, and if this goes on for more than 4 hours of a high-grade torsion, you can develop scrotal erythema, induration, and edema in the later stages. Barbosa presented a classification or stratification for risk, which has been somewhat helpful, especially if you're seeing a patient in the office or the emergency room. If there's testicular swelling, that's 2 points. Palpably hard testicle is 2 points. Nausea or emesis, 1 point. A high riding testicle, 1 point. And absence of a cremasteric reflex. So you can have as many as 7 points on this scale. Low-risk patients are 0 to 2, and the negative predictive value is 100%. The sensitivity was 100%. If they're high risk, that's 5 to 7 points. Those patients should go straight to surgery. You don't even need to get a sonogram on those patients. The positive predictive value is 100 and specificity is 100. Now, 80% of the patients in this study fell either into the low or high risk categories. Those in the middle, where it's equivocal, should probably be explored. The clinical diagnosis is for an exploration is warranted if it is suspicious or equivocal. You don't want to wait. If you can't really tell, have the surgeon take them to the emergency room or have the patient in your office go immediately to the emergency room. We usually have less than 6 hours to save these testicles. You can get a urine analysis if you're not sure to look at infection for epididymal orchitis. And once they get to the emergency room, an ultrasound with Doppler is highly effective, but it can't be relied on. The clinical judgment is the most important thing here, with a 90% sensitivity, 96% specificity, and a negative predictive value of 98%. But even if you have blood flow, you have to remember that these testicles can intermittently twist. So on the way to the emergency room, they can twist back and relieve themselves, and that child is still susceptible to redeveloping this. So if you have a high suspicion, get them to the emergency room to be evaluated and followed closely by the urologist or the surgeon. If you have a child that's in a lot of pain and you have a high suspicion that this is torsion, you can detort this manually. Typically, if you're facing the patient, you want to do an open book rotation. So if you have your hands on each testicle, you want to rotate out like you're opening a book. Over 2/3 of these patients will rotate inward on both sides. So you want to rotate outward, and you can relieve that torsion and reperfuse the testicle before they get into long-term damage. Outcomes, ischemia, depending on the degree of torsion and how long, 4 to 8 hours before real ischemic events begin to occur. And again, that depends on the degree of torsion and the length of time. But in a full torsion, we have less than 6 hours with a salvageable rate of 80 to 100%. After 12 hours, there's less than a 20% salvage rate. Now, getting back to the anatomy, the intravaginal, which is the most common, also known as adult or adolescent torsion, is where the testicle actually acts as a bell clapper and spins inside the tunica vaginalis. The extravaginal torsion occurs in neonates, less than 6 weeks of age, and full-term males. And this occurs where the entire tunica vaginalis and testicles spin on the cord. And that's because it takes about 6 weeks postnatally for the tunica vaginalis to adhere to the scrotal or wall to anchor the tunica vaginalis. So prior to that, these neonates will present with torsion, and this is again extravaginal torsion. These children usually present on routine exam in the neonatal unit or at home. They'll come to your office because the parents think that the scrotum looks different or it's swollen. These tend to be non-tender by the time they're examined or identified. That the inflammation causes a fixation of the tunica vaginalis to the scrotal wall, and the testicle itself is usually not very mobile within the scrotum, and there's discoloration of the scrotal skin. It's impossible to save these testicles, so there's no reason to urgently go to the operating room, or if the patient is in the NICU and you see this, it's nearly impossible to salvage these by the time they're discovered. The real issue becomes saving the good contralateral testicle, because that testicle will also be susceptible to torsion. And right now it's pretty controversial as to when that baby should go to the operating room to have the contralateral testicle fixed or pexied to prevent torsion. In our hospital, with good pediatric anesthesia, most parents after consultation would prefer to have that done, and it's done scrotally through a simple scrotal incision. We usually do these under a low spinal anesthesia to resist and avoid any general anesthesia. Moving on to torsion of the appendix of the testis or epididymis. This is much more common than testicular torsion, and in some males, not every male, the appendage of the testis is located in the upper pole as well as the appendix of the epididymis. Both of these are upper pole appendages. The appendix of the testis is a remnant of the Müllerian structures that did not fully absorb, and these can be of different sizes from very small to quite large. They look like a teardrop. They have a very large head and a very skinny neck, and these can rotate around that neck pedicle and become necrotic. And again, these are often intermittent, so you will get a history of intermittent acute testis pain, and it can present just like testicular torsion. Again, it's acute in onset. However, there is a lack of dysuria, fever, avoiding symptoms, so it often mimics an infection such as epididymal orchitis. Some of the pearls with this, when you're examining a child with acute scrotal pain and you're suspicious for torsion of the appendix of the testis, they're often less painful than a child with testicular torsion, but unless you've seen a lot of patients with testicular torsion, you're not going to be able to tell the difference. But if you can hold the testicle and push it up against the skin on the anterior surface of the scrotum, you can often see a dark, often blue dot. That's pathognomonic for torsion of the appendix. And if you can carefully examine the testicle and there's point tenderness in the upper pole, and there's no elevation of the testicle, none of the other stigmata of testicular torsion, then you're likely dealing with torsion of the appendix of the testis. An ultrasound can be done to look at blood flow to rule out testicular torsion, and in a urine analysis for epididymal orchitis. Very often, after an ultrasound, the report on the ultrasound will come back epididymal orchitis because of inflammation and hyperemia of the epididymis and surrounding tissues, and the child will be discharged home with a diagnosis of epididymal orchitis with a negative UA, no fevers, no other reasons. It's just misdiagnosed and often overlooked. You treat these patients with NSAIDs, warm compresses, bed rest with scrotal elevation, and surgery is indicated if it's not clear or there's questionable what's going on in that scrotum, or the pain doesn't go away or is intermittent. The child can go to the operating room with a scrotal incision and excision of the appendix of the testis. Epididymal orchitis is another very common thing. Again, in our experience, a lot of these are misdiagnosed as missed torsion of the appendix. However, in the clinical exam, you'll find that these patients with true infection tend to have a slower onset. The pain can be severe, but there's a crescendo effect over about 3 to 5 days where that gets worse. The scrotum is swollen, it's warm, there is erythema, induration, and it's very difficult to localize a point of pain. And it's important in these patients, if you suspect epididymal orchitis, that you need to consider voiding dysfunction, urologic instrumentation, whether they've been catheterized recently, prior infections or UTIs, any anatomic abnormalities, which we'll talk about briefly, fevers, sexual activity in the adolescents, or any history of urethral discharge. On an ultrasound, epididymal enlargement, it can be seen. Here's a testicle with a markedly enlarged epididymis, and this can be also pathognomonic for torsed appendix testis. A torsed appendix testis can look like this on an ultrasound. So you have to have a good sonographer to help you differentiate that. And you can see that there's a significant increase in blood flow, which moves you away from any type of torsion and points more to an infectious etiology. The causes of epididymal orchitis, most of these are idiopathic, and I believe that those are the missed testicular torsions, of the appendix. But coliforms and mycoplasma in the younger kids, gonococcal and chlamydial infections in the sexually active adolescent, E. coli if there's an anatomic GU disorder such as posterior urethral valves, urethral strictures, or meatal stenosis. Viral if there's a history of generalized symptoms or constitutional symptoms, and can also present in the presence of mumps, adenovirus, enterovirus, influenza, and parainfluenza infections. You want to get good urine cultures and then start the patient on empiric antibiotics and then adjust for sensitivities, particularly if the UA is positive or you have a sexually active adolescent, or if you can detect any anatomic abnormalities. These patients are treated not only in addition to antibiotics, scrotal support, NSAIDs. If they have a very high fever and pain cannot be controlled, admission is advisable, and it's rare that we would ever need to do any surgical exploration. Occasionally, the acute scrotum can appear in the presence of an inguinal hernia. Here's a child with an extensive inguinal hernia. This would be a tender area and fairly firm. On ultrasound, you can see bowel. Here's the hernia sac. Bowel is extending down, so this is an incarcerated hernia, and that can also put pressure on the spermatic cord, which can cut the blood supply off to the testicle, which is seen here. First thing to do is to try and reduce the hernia. And if you're able to do that, you can get blood flow back to the testicle. But if that's not picked up early and the sac is not reduced, you can actually lose the testicle, and this is evident during the hernia repair. Hydroceles, there are two general classifications. There's communicating and non-communicating. The non-communicating tend to be seen right after birth as the testicle descends into the scrotum and the sac closes off. It can trap peritoneal fluid. Those we tend to watch. They often always get absorbed. They're non-painful, non-tender on exam. But the communicatings are the ones we're concerned about. So if you have a child with scrotal swelling that's non-tender, you suspect a hydrocele, ask the parents, does it fluctuate in size? Does it get worse when they're crying or coughing? Has it progressively enlarged over the last 6 to 8 weeks? And is it extending up into the inguinal canal? All of these would be indications of a communicating hydrocele, and those are the patients that should be referred to your surgeon. This is a baby with bilateral scrotal enlargement. And on exam, these are very tense hydroceles. If you cannot feel the testicles, you should get an ultrasound to validate that they're down and that they're viable. Also, squeezing these, if you can squeeze these down and they decompress, put your hand over the ipsilateral lower abdomen to see if you can feel an increase or mass in the abdomen when you squeeze, and that can be an indication of an abdominal scrotal hydrocele, which often gets missed, and those need to be seen and corrected fairly quickly. Trauma is another cause for an acute scrotum. This is some sonograms from a boy that I saw who had a dirt bike accident. He said the pain occurred right after he hit the bike when he fell, but the pain went away within about an hour, but he had a massively swollen scrotum. And on ultrasound, you can see this heterogeneity in the testicle. There's areas of good blood flow within the testicle, but you can see here's the hematoma. It's extending around the testicle. The trick with these is it's very hard to differentiate those from just a contusion. A contusion, they can develop a hematocele, which is blood outside the testicle within the scrotum. They can develop a reactive hydrocele, or they can have rupture of the tunica albuginea. And that's very difficult to pick up on ultrasound. This is an example of a patient, and we took him to the operating room, and you can see that the tunica albuginea is shattered. And in repairing this testicle, you have to debride this, and you have to be very careful when you reapproximate the tunica albuginea to debride this enough so that the post-surgical swelling will not increase the pressure, because that'll be a closed space and cause tissue necrosis and loss of the testicle. So the goals with those are to debride the devitalized tissue, put them on antibiotics, and then correct and reapproximate the tunica albuginea. And we're going to move to some penile issues. It's important, the foreskin develops at around the 12th week of gestation and then migrates forward to cover the glans penis. There are two layers. There's an inner and an outer squamous epithelial lining. And that inner squamous epithelial lining begins to keratinize at about 6 months of life. Prior to that, that inner lining is adhered to the glands, and those are the physiologic adhesions that we often will see if the foreskin is loose but cannot be fully retracted. Now, back in 1949, this was what we saw. About 50% of 1-year-olds would have a retractable foreskin, 80% of 2-year-olds, and 90% of 3-year-olds. But today, this has shifted way to the right because of the absorbent diaper. The absorbent diapers desiccate the foreskin and can result in scarring and a delay in reducing the foreskin. And this can also increase the risk of meatal stenosis. That very delicate meatal tissue can be desiccated by these absorbent diapers. Prior to 1980, the incidence of this was very low. The absorbent diaper came on the market in 1980, and now we've seen an exponential increase in not only pathologic phimosis, but meatal stenosis. So we're recommending today that all newborn boys who are using absorbent diapers have the parents put some sort of diaper rash cream or Vaseline on the inside of the diaper where the penis is exposed, and that will almost eliminate the incidence of meatal stenosis and significantly improve and lower the risk of physiologic or pathologic phimosis. The causes of phimosis, most of them are physiologic, as in this child here. This is a typical tight foreskin that you might see in the office. But you also, in the older boys, you need to be thinking about BXO or lichen sclerosis. In the United States, lichen sclerosis is on a significant rise, both in males and females. If you identify it, you need to treat it. If they're having recurrent urinary tract infections, uncircumcised boys have a 15% higher risk of urinary tract infection if they're uncircumcised during the first year of life compared to their circumcised cohorts. They can develop voiding difficulties where the entire foreskin balloons out when they're urinating, and they can develop infections in the skin, such as balanoposthitis. And you want to treat them if they don't outgrow it. What that time is really dependent, whether it's at grade school or at toilet training, and if it's associated with a buried penis. The treatment usually includes topical steroids, such as betamethasone. That's the first line of therapy, and this works really well. But the trick with betamethasone or any other topical steroid is you have to take the time to show the parents how to put it on. If you just rub the cream on and leave it, it doesn't work very well. You will get a significant improvement using these steroid creams if you have the parents massage the cream into the skin for about 10 to 15 seconds. I usually tell them it's like putting on hand lotion. You want to work it into the tissue. If you have them work it into the tissue, the success rate is significantly higher. And we usually will have them apply that 3 times a day for 1 month and then reevaluate them. Meatal stenosis is a common thing that you'll see in the office practice. Up to 15% of circumcised boys post-1980 will develop this, and I believe it's mainly from the diaper. We used to think it was because of cutting the frenular artery during a circumcision, but that doesn't explain the rapid increase since 1980. I think it's more due to these absorbent diapers. The mean age at presentation is 4 years, and on physical exam you will notice a narrow, very tight meatal stenosis, sometimes just a pinhole opening, and they can present with dysuria, hematuria, urinary tract infections, or frequent urination. And very often, if you ask the parents, if it's a toilet-trained child, when they stand to urinate, do they have to push the penis all the way down to get the angle so they can hit the toilet? Because usually the stream comes way up, almost at a 90-degree angle. Treatment is topical steroid creams work great 3 times a day for a month. If not, an in-office meatotomy can be done. If it's associated with BXO, that's a much more serious problem because BXO can extend into the urethra, and many of these kids may need a urethral surgery to remove that. The buried penis. How many kids have you seen where the parents say, my son's penis is too small, I can't see it, I changed the diaper, and you don't really see anything but maybe the end of some foreskin. You can tell them that that's okay. The key thing is to palpate the erectile bodies to make sure you can feel a good size, normal sized penis under the fat pad. And what happens in a lot of these boys is the perigenital fat pad, that skin along the penile shaft is not attached to the underlying tissue layers of the penis, and it elevates so that the foreskin becomes ballooned out and the entire penis is hidden within this fat mound. It's more of a concern from the parent's point of view. Usually it doesn't cause any pathologic issues, and the children will outgrow this with time as the penis grows and the fat pad resolves. However, it can cause severe stenosis and trapping of the penis, so the penis cannot be exposed at all. And in those cases, some of these patients, if the fat pad doesn't resolve or they're getting infections, surgery to perform a circumcision and then tack the fat pad back can be done to get the penis exposed so that it will function without any issues. Penile trauma is another thing that you'll see in the NICU and in your private offices and pediatric offices. Most penile traumas are related to circumcision, but there can also be strangulation, usually from hair that gets into the diaper, will wrap around the shaft of the phallus and cause a hair strangulation. That's the most common cause. Bicycle accidents, animals, and zippers are a big issue. So some of the traumatic injuries that you'll see, this is a patient who had a circumcision where the frenulum was elevated underneath the clamp, and when it was cut, it opened up the ventral aspect of the meatus. Here, the same thing has happened, and there was excessive scarring of the circumcision site. Here, they were using a Gomco clamp with electric cautery to kind of cauterize the edges, but they didn't realize that the Gomco clamp is metal and transmits electrons, and burnt this child's phallus. And using the Mogan clamp, you can get the entire head of the penis or glands through the clamp and disarticulate the glands. This is a fairly common thing that we see after newborn circumcision where there was excess skin removed. Here, there's an absence of skin from the coronal sulcus to the shaft, so all of this has been denuded. And in those situations, you can either reapproximate these edges, which we don't recommend because that will end up with a short phallus. Skin grafting is really not necessary. You can replace the removed skin if it's fresh. That usually will have a good take. Or you can just dress this area with a bacitracin or Vaseline gauze and let it epithelialize with secondary intention. In the newborn, that works very well. So it doesn't need to be surgically corrected. However, there are amputation issues. This is a child that I saw who was having a bris and came into the emergency room with an amputation of the glands and the distal foreskin. If you get a call that this has happened, have them wrap the excised tissue in gauze, place it on ice, and bring them immediately to the hospital. These can be surgically reattached. It does take microsurgery. You have to be very careful about that. 2 weeks later, you will see excise sloughing. This looks terrible at 3 weeks, but then at 6 weeks or 4 weeks, you can see that this eschar has removed and the glands is viable and healthy. Strangulation, a hair strangulation or a hair tourniquet is very common. If you see a child with a very distal dilation, an inflammation, take a close look at where that transition point occurs and look for a hair, because you can cut that and relieve it. And if you take care of this early, these children don't have any long-term issues, but if it's delayed, they'll need complex reconstructive surgery. Paraphimosis in the uncircumcised male presents with pain, edema, and vascular engorgement, which prevents the foreskin from being able to be brought back over the head of the penis. If you see this, take a cold washcloth or a towel or gauze pad, wrap it around the penis and squeeze it for about 10 minutes. And then try to reduce it by taking your fingers to pull the foreskin forward at the same time you're pushing the glands backwards. If that doesn't work, you need to numb it and then incise the tight band to get the skin relieved, or a formal circumcision. Otherwise, these children can lose the glands. Micropenis is a very controversial area in the past. Many of these patients with true micropenis had been raised as females. We know today that that should never be done. These are babies that are born with a small phallus, stretched penile length less than 2.5 standard deviations below the mean. In other words, in a full-term newborn, anything less than 1.9 centimeters. And this is based on corporal length, not the foreskin. Testicles are usually small and descended, and interruption of the penile growth occurs after 14 weeks. The penis is fully formed at 14 weeks, but hormonal stimulation can be interrupted that prevents the ultimate growth of that. This is driven by the hypothalamus with GnRH stimulating the pituitary. LH is released stimulating the testicles to release testosterone. Testosterone is peripherally converted to DHT. It is DHT that causes penile growth, not testosterone. The main etiologies of these, over half of them are hypogonadic hypogonadism, hypergonadic hypogonadism or gonadal dysfunction, and 25% end organ sensitivity, such as androgen receptor defects, and 15 and 10% of these are unknown. The most common cause of adrenergic hypogonadism or Kallmann syndrome, Prader-Willi syndrome, Lawrence-Moon-Beadle syndrome. And if you have these, you should be getting a renal ultrasound to look for unilateral renal agenesis or cystic dysplasia. Testicular failure associated with micropenis, commonly seen in Klinefelters, testicular regression syndrome, and LH receptor defects. You should assess the endocrine function, get a karyotype and an MRI of the brain to look for any pituitary issues. Document a response of penile growth to androgen stimulation. If there's a poor response, androgen receptor assessment should be considered. You should never assign these patients, if it's a 46XY male with a microphallus, do not assign them a female gender. 100% see themselves as male ultimately. And 60% will be sexually active, and 20% of these patients will have some degree of need for psychological support. And that gets us through the talk. Thank you.